everyone. Thank you so much for joining our meeting tonight. We have Dr. Buckhold here who is going to be talking about his experience with internal medicine. We're going to start with some questions from Aman and Aaron, and then after that, we'll open up questions to the audience. So we can go ahead and get started.
Hello, everyone. My name is Aman. As Blake told you guys, Aaron's my co-host. Today we have Dr. Fred Buckhold, who is an IM doc and a hospitalist here at St. Louis University School of Medicine. So we'll start with some questions and we'll finish by opening up to any questions you may have. Without further ado, thank you, Dr. Buckhold, for being here with us. Can you start by describing your medical journey and where you conducted your medical training?
Sure. So, good afternoon or evening, everybody. So, I'm Fred Buckhold. So, I guess probably the better word is a general internist, and I also am the residency program director. So, I run the core or main internal medicine residency here at SLU. I'm like you. I started med school. We'll just say a couple years ago. Actually 2 decades ago now. So, I started in 2003, which makes me want to cry. But so I did my medical school here. And then after graduating in 2007, did my residency here. Internal medicine residency is 3 years. So I did all 3 years of my residency here, and then I joined the faculty right after that. And then I've been, when I started, I worked as a general internist. So I saw patients in clinic. I rounded in the hospital, usually almost exclusively with other learners, so residents and the medical students that are on the IM clerkship. And then was in 2014, I became program director. So I've been in my 9th year doing that, which is really technically half my time, but really probably takes up 2/3 of my time, I think, in principle. But I still see patients around in the hospital quite frequently. I see patients every week in clinic with residents. Once in a while, I'll see patients on my own. And I do just kind of other random things. So the nice thing now about my job is SLU is expanding, the hospital's expanding. So there's all these little holes where they need people to fill in for some extra money. So that's been really nice the last couple of years.
All right, awesome. Thanks for that introduction. So now what do you think med students should know about internal medicine, or more specifically hospital medicine, like what your schedules may be like, any procedures that you do on a day-to-day?
Sure. So I think first and foremost, internal medicine encompasses the care of the adult patient, usually around 17 or 18, all the way through to the end of life. I think what separates there are other specialties that do that, notably family medicine. I think the philosophy and like kind of core principle of an internist versus a family medicine physician is basically kind of the focus on the adult, and then really just kind of a familiarity and experience with complexity. So where most internal medicine physicians train are in large academic centers across the country, and those tend to be very sick, complicated patients, and that's where the bulk of experience is. So I'm very comfortable with, and I think most of my colleagues are very comfortable dealing with very, very ill patients, kind of with a lot of needs and a lot of chronic illness, and dealing with that in a competent way and trying to make their health better. Prevention is a big part of our job too. So, in the hospital setting is different than in the outpatient setting, but we also have a focus on trying to do preventative care wherever we can. So in the hospital, when we see patients, we'll try to give them the vaccines. We'll certainly counsel on smoking cessation, start the management of chronic illnesses if we need to. So they're newly diagnosed, say, with high blood pressure or COPD, we'll certainly initiate and start that manage and arrange appropriate follow-up. If we're focusing on the hospital side, there's a couple of different ways things do it. Typically in medicine, we'll break practice types into kind of 4 quadrants, so to speak. So there's really the practice types, so hospital medicine and outpatient medicine or ambulatory medicine. It's exactly what it sounds like. A hospital-based provider typically sees patients mostly in the hospital. An ambulatory provider typically sees patients in what we call primary care in the outpatient setting. Although a lot of practices do both. So a number of my partners will see patients both in the hospital and outside the hospital. We're kind of morphing so that we see our own patients in the hospital is kind of an example of that, and that's kind of unusual. Some of our hospital-based physicians see patients in what we call our hospital-based clinics, which are really focused around discharge or trying to prevent people from coming back into the hospital, which is an important piece. So there's always kind of this blend, and internists live in what we like to brag that we live in a world of gray. There's no absolute. So there's a lot of fuzziness between what a hospitalist does and what outpatient doc does. The other big part of practice is what we call academics or private practice. So private practice is, really just either, traditionally would be kind of setting up your own shop in like an office. That really is kind of a dying, if not dead, model. Usually private practice is just, something where you're in a large physician group. It may be for-profit or a nonprofit, but it's not affiliated with any kind of teaching activities. You're seeing patients, you're doing really what the practice needs and wants. And that's what private practice is. I'm an academician. I'm in an academic practice. It's a little goofy now for reasons I won't go into because they're not that interesting, but I'm affiliated with teaching. So I'm involved with teaching the students and residents. The demands of my time are a little bit different. The pace is a little bit different. And academics, so that's kind of the big difference. With hospitalists, and again, the reason I'm getting into all this is like with a hospital, particularly a hospital-based physician, there's a lot of different models that are kind of morphing out into things. So the hospitalist in today's world needs to provide 24/7 coverage for inpatients or patients admitted. So that gets broken up a lot of different ways. There's some people that are what's called nocturnists, whose job it is to really just see patients at night, either to do admissions or do cross coverage. It's kind of an interesting gig if you can deal with the nights. You don't have to. You work typically about 10 days out of the month, maybe 12 in the most extreme example, and get a pay differential for that work because not many people want to do that work at night. So it's a really important position and an important piece. A lot of residents do that right out of residency because it's not that hard to do after kind of being a resident for a couple of years. Then you have day crews, so to speak, so people that aren't here at night. Those come in a lot of different flavors. Some people do 7 to 7 shifts, so work 12 hours straight. Some will do kind of a 7 or 8 o'clock in the morning to 5 o'clock shift, and then there's another person that comes in. There's models where people work what's called 7 on and 7 off, so you work 7 days straight, and then you have 7 days off, which is sort of the model we have here at SLU. But when your group gets sufficiently large, you can kind of, that becomes a little bit more malleable. You can kind of negotiate with other people and develop other structures to get that. So it's a piece that's evolving. I mean, classically, you'll see kind of the classic schedule is 7 days working straight, then you have 7 days off. But, I think a lot of practices as they get large kind of want kind of a more flexible work environment. And that's what a lot of practices are on too. So it's been very nice, I think, in the last 5 or 10 years where the practice is incredibly flexible. And then Aaron, I can talk a little bit about outpatient, but do you have somebody else on the outpatient side that you guys are doing, or I don't know if you guys need information about that.
You feel free to talk about it if you know a little bit about it.
Okay, so the flip side of this is what's called ambulatory medicine, and that's really seeing patients in clinic. At the tail end of it, most places, like if you're really working full time and really want to have your productivity high, you're talking about 8 to 9.5 days of clinic a week. So, working a morning and an afternoon. Usually most practices have at least 1, if not 2 half days just for catching up with phone calls and paperwork and whatnot. The nice thing about that is you have your weekends off. So like, I didn't mention, but I've got 4 kids that are like, 2 are teenagers and 2 are like preteens. So like having weekends off for me is really nice because I can do stuff with them on the weekend. So that's the other thing too. So that's where you're seeing patients in the clinic. You're seeing them repeatedly and following up and developing a more longitudinal relationship.
Okay, I wanted to switch topics a little bit, and I wanted to ask you, was there a specific like aha moment that you knew you wanted to do IM? If you could talk a little bit about that process for yourself.
Sure. No. I kind of had a sense that I actually wanted to do medicine pediatrics as a combined specialty, which is possible. So it's where you're doing kind of a combined residency in internal medicine pediatrics. I always thought, so kind of a couple ways to think about all specialties. There's really kind of 3 large types, 2 of which are what I call kind of more front facing. So that's and the first group of that is what's called the cognitive specialties. So again, although I have some procedural skills and technical skills, and some of the subspecialties in medicine have some technical skills, we all trained initially as cognitive specialists. I see patients, I ask questions about what's going on, I use my knowledge and intuition and experience to kind of make a decision about what's going on and act accordingly. The second big group of people that are really patient facing are technicians. And I don't mean that in any derogatory way whatsoever. It's a skill set that is a wonderful thing to have. So these are your surgeons of all different ilks in medicine. These are your cardiologists to some degree, your gastroenterologists. And of course, there's a cognitive component to all that. It requires an immense amount of knowledge and skill. And then the third kind of group is people that are kind of behind the scenes that have a different skill set that's really important for patient care. So pathologists, radiologists, there's probably more that I'm missing. So I was kind of knew that I wanted to be a cognitive type specialist. I didn't think about it at the time, but I didn't really want to do technical work. I really enjoyed the thinking aspect of medicine. So that's where I always thought I was going to be. It's interesting, and you probably had the same journey and experience. When I was a med student, no matter what I did, everybody kind of wants to recruit you to their tribe, so to speak. So like when I did urology, urologists are like, oh, you should do urology. I'm like, I have no desire to do that whatsoever. Or you do pediatrics or surgery and whatnot. And I just kind of wanted to go my own way and kind of figure that. And so I was naturally drawn to medicine as a kind of field. I liked dealing with the adult patient. I didn't like dealing with the kids, so I did that during my clerkship. Actually, the kids were fine. The parents were the brutal part of pediatrics for me. So I just kind of naturally gravitated towards that. And that really was my personal statement for residency is like, I think I'll be good at this. Like this seems to fit my talents, but there's no aha moment and you don't need to have one. I think most internists like everything. Again, I think we find everything interesting, but there'll be a lot of different fields that are like that too.
And then further in your career, like how did you come across or how did the opportunity arise where you became a program director for the internal medicine residency program? Can you talk about that?
Sure. For me, pure stupid luck. So I was never. I'm not a very good person to like get career advice about because I just kind of fall into different things. So when I finished, when I was a resident, my nickname was the professor. So I had been talking about being a teaching physician a long time. What I really loved doing, what I wanted to do is just, and you'll see us on third year clerkships, is just like round with a team, talk about medicine and teach. Like I found that fun. And that's what I kind of wanted to do. When I first kind of signed my contract with SLU, one of my mentors who was an attendee with me just kind of mentioned, he's like, hey, I'm going to be a program director. How do you feel about being an associate program director, which is assistant program director? I was like, sure. I didn't even know what that was. I had no idea what it entailed. But for me, what happened was over the course of 4 years of working with him, his name is Miguel Paniagua, he really showed me what it's like to not just like teach at the bedside, but develop curriculum and think about structure and how to make what's called assessments. So how you evaluate residents and kind of coach them through. And when he left, again, this was 2014, like interesting enough, Dr. Miller was also applied for the job. I would say I beat him out, but I didn't. He actually withdrew because he had a family situation in New Orleans. So he came a year later, but he would have been a great program director too, probably better than I ever would have been. But so when that job came up, I applied and got it, and I've been doing this ever since.
Awesome. Thanks for
Be sure to say,
sharing
if you ever
that.
say Dr. Miller, quote it, say I told him I beat him out for the job. Make sure he knows that. So.
So just to shift gears a little bit, obviously we're all med students. I think we're all M1. So looking back on your time in med school, is there anything you wish you had known or done differently when you were a med student?
I don't. That's a great question. I haven't really actually thought about that. What I did well that was helpful, and it probably helps that I was a physiology major in undergrad, but it all goes back, and I'll talk to you guys when we do the cardiovascular module later this semester. Everything goes back to like the basic core things. So physiology, some degree pharmacology, pathophys and pathology particularly, and you really start to build first principles from that. So, when I was a student, we had less in the first 2 years of kind of clinical reasoning and thinking through things, which I found really interesting. So I wish I had more of that earlier on to kind of get me thinking about these concepts in a way that doctors think, so to speak. Um, and I guess the other thing too is I wish, probably explored a little bit more in terms of just different opportunities. So not necessarily in specialties per se, but I would have probably enjoyed doing research a little bit more at the time if that opportunity was there, maybe getting in the clinical environment a little bit more. But what's nice in med school is even now, like I know you probably don't feel it and like you're tested up the wazoo still, but this is also a time where you can kind of find things that interest you and pursue that a little bit. Certainly later on in your med school career, you'll have that. And I was given that advice and that was really helpful too. So particularly my fourth year, I kind of found things that were more interesting to me. I kind of wish I did that earlier on because I think it would have got my curiosity active a little bit more. Med school does have this phenomenon of beating a little bit of your curiosity out of you. And I don't know how to fix that, but it does do that. I don't mean to say that cynically either. Sorry about that. It just does.
Can you talk a little bit about what students can do to prepare for like IM if that's something they wanted to do? Do you have any advice concerning that?
Well, I think honestly, SLU does a really great job getting you prepared clinically. So the not just IM, but some of the other really core third year clerkships are really fantastic at getting a really good exposure and kind of helping you figure out what you want to do. And I think no matter what, explore all of that with an open mind is really cool. Perfect example. I really liked OB a heck of a lot more than I thought it would. It's my first clerkship that I had, and I was kind of dreading it. I didn't think I would like the OR, but I actually really enjoyed it with them, and I had a really great set of residents I worked with. So like, if I had a closed mind to that, I probably would have just not enjoyed that experience nearly half as much as I did. So that's probably the most important thing. But again, the key thing is now, and I'm curious, I don't know how you guys are approaching things. I guess you have no reference point compared to previous classes, knowing that step one is pass fail, but you can kind of spend some time learning stuff because you want to learn it. And like, if you build those good foundational blocks, you understand your phys really well, you'll hear me say this in a couple of months. And so I'll start it now. I will not ever stop saying it. It's like, half my clinical reasoning goes back to thinking about something called the Frank-Starling relationship, the basic physiologic relationship between volume of blood and the cardiac output of your heart. And, because I understand that so well, I can work backwards and figure out problems really nicely and make clinical decisions, and then be prepared for when I'm not sure about something, I make a decision, I'm not sure it's right, I'm ready to act on that when it's wrong. And that's all that a lot of these kinds of specialties are about is about thinking through problems and being ready for unanticipated changes. And it all starts with like those basic blocks. So now just do what you probably do and study get to understand these fundamentals well. And, then as you start to apply it, really kind of use that basic knowledge to get through it, that it helps a lot. And I was given that same advice when I was a third year. It was actually an OBGYN that told us this, and I didn't understand at the time. It was like the smartest thing that she ever said or I ever heard. It took me probably 5 years to understand it, to be fair. So by the time I'm telling you this now, you'll be like a second year resident and you'll start to get it.
And following up with that, kind of the same question, but more applicable to your role today. So like, I guess kind of give a primer of what your job entails as a program director. And then like, what are you looking for in a good applicant to residency?
Yeah. So what is my job? So I don't even know how to start. So we have 85 residents in this program. So like basically it's just managing that group. I have a massive team, so there's lots of different people involved. I guess I'm part of the figurehead, but I think a lot of my work is just having conversations. So, 2 of my hours today, we're meeting with residents, just talking about different stuff, a couple one-on-ones. Other days it's doing other teaching. Other days I'm thinking about structure. We just finished up interviewing, so like that was massive. So we interviewed 350 candidates for 31 positions, I should say. I meet every single one, so that takes I don't want to talk about how much time that takes, but it's really fun. So I do a lot of different things, teaching, and I think it's important that I'm out there in the field clinically teaching and doing clinical work. So that's the basis of what I do. There's a lot more to it, but it's really more the relationship building that I think is my most important role. And second would be kind of working on the environment, making the environment better for our residents so they can do their work productively and not be, worn out all the time, which I think we've done a good job with. The second part is about application. And, it still goes back to, the way I kind of think about it, and I'm a little different, but I'm not alone in this thinking is, I think what every program director wants, no matter what you want to go into, is from day one, is this somebody that will go about doing the things that need to be done the right way. This is where SLU does actually a really phenomenal job. They train really good clinical students. You guys are very prepared to go whatever you go into and be, able to do kind of the basic work from day one, which is really an asset. And that's kind of the first thing is just like, do I think this person did reasonably well in med school? And what I always joke is it's kind of interesting in medicine and other fields too, is you can have lots of people that look great on paper that they end up being really only so-so residents. When I say great on paper, like good scores, did pretty well in clerkships, et cetera, et cetera, et cetera. We pay a lot of attention to how people are at the bedside. So, I certainly will take somebody with a lower step 2 score, but it says very clear, like when you put them at the bedside, they're really kind and really nice and a good person to work with. Those are actually the people that end up being my chief residents more often than everything else and future faculty. So I really kind of look for are these just like decently nice human beings that like would get along with our crew really well? Do they represent a diverse set of viewpoints? Those are really kind of things I pay attention to. So I think that's really the key to success is like kindness, empathy, grace on top of like being competent. I'm trying to I haven't figured out how to write it yet, but I'm working on a blog post now where our former CEO of the hospital, we were at a Christmas party and she said, Buckle, we like you because you're competent and nice. And I said, I joked, I was like, would you rather have somebody competent or somebody nice? And she said, yes. Like the minimum requirement is that you're a competent, nice human being and a competent physician. And I think that's the approach I would take. And again, unbelievable good piece of advice for just growth and a really great and satisfying career anywhere in medicine, but particularly IM.
And then going back to your role as an IM physician, what is your favorite part about your job and what maybe is your least favorite part?
Least favorite is paperwork. I think that's everybody's least favorite thing, but it's a necessary part. Honestly, my best days, like I love working with students and residents. It's so much fun. But like there's just certain days, like I just was covering a weekend a couple weeks ago, and I'm just in a room with a patient and his wife, and I'm just we're talking a little bit about medicine, answering questions, and then excuse my language, you're just shooting the bull. And just to be in a room and like making, talk to somebody and have develop a kind of a quick relationship, help them through, what's essentially one of the worst days of their life, which is them being in a hospital. And, just that dopamine rush you get from that is just the best. I will always, a lot of things can happen to any of us, but as long as I have the ability to go into a patient's room and just talk medicine and get them feeling maybe hopefully a little bit better, is the best. There's nothing better than that.
And how do you balance keeping up with other hobbies and interests while being a doctor? Because it sounds like you're a very busy physician.
No, this is where you just have to set limits and rules. So, I'm pretty protective of my weekends. I try to get home at a reasonable hour, although not tonight, obviously, but it sounds like my kids are cranky, so I'm in no rush whatsoever to get home. But I think it's I try to make all my kids' activities so I don't miss soccer games or dance events. Try to make protected time for that. And I'm very definite about that. So if I have the weekend off, I'm not doing work, I'm not answering the phone when it comes to work unless like my immediate bosses call me. And I think that helps a lot. I'm getting ready to go. Well, we're planning a big trip to go to Europe this summer. Like my phone will be off. I will not answer a thing. Like I just make very clear boundaries about things, and I think that helps a lot. It helps a lot. And I should emphasize, I have that luxury too. you know, when you're a resident, it's a little bit harder, but like, again, when you're on vacation as a resident, you know, you're not expected to be around, and like making sure you have those breaks to get away is helpful. I think it really does help keep your sanity.
And then just to follow up from before that we kind of forgot to touch on, since you are an IM physician, but you decided to work in the hospital setting rather than outpatient, is there a reason that you decided to do that in one over the other?
No, so interesting enough, I go back and forth. So I'm kind of like the utility man in this practice. So you know, when we're short in one area, I tend to do more than the other. So I'm still, you know, a couple years ago, I kind of morphed over to the hospital side. I do see patients in clinic now. So the advantages of both, like what's nice about being a hospitalist is like the lack of follow-up. Like you don't have clinic phone calls or patient needs calling in. You don't have to do a bunch of refills or deal with paperwork as much, although that's gotten a little bit more chaotic for hospitalists. So like it's really nice in terms of definition. You come in, you do your work, you go home. I will say, particularly a place like SLU, and SLU is like one of the highest. I don't think you guys realize, you may not understand that the hospital here is insane. It has probably one of the highest acuities of any hospital in the country. It is a very, you know, busy, challenging place. So I will say, like after a good week of doing hospital medicine, I'm fried. My brain is pretty tired, and you know, I need that recharging, and so you don't always get that. So you know, I kind of like the idea of going back to doing some clinic work because I have, you know, I have my weekends and I can have some time to think about that. And I like seeing patients over time. So I like both. Some want more of that pace and excitement. I think a lot of people out of residency want that excitement. Whereas, you know, particularly as you maybe, you know, thinking about a family or your kids are getting older and you want to have, you know, more time with them and they're in school during the week, it makes sense to do things, you know, on the weekend, and people kind of switch back or kind of back and forth. The beautiful thing about internal medicine is you can, I mean, I have that flexibility. It's not much of a change in skill sets to go from one place to another. The thinking is very similar. Some of the tactics are a little bit different, but they're easy to pick up. So it's a very flexible, you know, I don't have the same career that I had 5 years ago. 5 years from now, you know, as an example, when my kids go to college, I'm thinking hard about, I may even be a nocturnist, you know, work 10 days, get that out of the way, and then go take off somewhere for 20 days. I have no kids. My wife, I can just go to Paris and like, who cares? So like the fact that I can even think about and contemplating that 5 years from now or 10 years from now is pretty awesome. And it's a nice skill set to have. We'll see if it happens. I don't know. Nights are rough. So
We've touched on the questions we wanted to get to, but before we finish up, is there any last pieces of advice you have for medical students?
that was a perfectly fair question. I can't think of any, but one will pop up as soon as we start talking about something else. But just enjoy this process. I know it's stressful. Every year gets better. Like second year is way better than first year. Third year is like 1 million times better than second year. Fourth is better than third. Internship, but it only lasts a year. But it does get better and better. But no matter what you go into, and that's the hard part about the journey with just med school in general. I assume everybody here is MS1s, right? Is that fair? Okay.
All right, so we will now open the floor to audience questions. So whether you want to put it in the chat and we can read it off, or if you want to just unmute, go right ahead.
Yeah. So Luke, good question. So the question that can everybody see on the chat? So any hard, fast metrics? So yeah, it's going to be different, but you know, if you ask program directors, step one, step two, clerkship grades are kind of the hard, fast metrics. There's a big push to get away from step scores. I think most good program directors understand that like step scores don't really predict great performance, and that's probably much more established in IM than it might be in other specialties. But you know, a perfect example. So we received probably 2,500 applications for really, we initially planned to have 300 interview spots, and we have 2 weeks to basically review them before we have to put out invites. Like it is impossible to get through all those. We probably reviewed a good 1,000, which is more than we've ever done, but there's no way to really holistically review all those applications. So you have to use something. So step scores and for us, graduation date and where they went to school. So like we know, for instance, we recruit a fair amount from SLU, recruit a lot from like Mizzou, University of Kansas, Illinois, Iowa. So we'll look at those schools first. And again, we paid a lot of attention to, having a diverse set of candidates. So we really made an effort to review, minorities in medicine and make sure we looked at those applications too. But yeah, that's the one big thing is step scores and then clerkship scores. A lot of schools, SLU is a little bit different. I don't know if they've talked to you or you're aware what SLU does. So SLU has two separate scores. So you'll have a clinical score. So basically how you do just in your day-to-day activities of being a clerk on the third year. That's one score, pass, near honors. The second score is basically what's called a shelf, which is a test you take from the MBME. A lot of schools, like, it gets kind of macabre and crazy. So like the test may be half your score, and you're never really going to fail the clinical unless you're really weird or odd or kind of creep something out or do something totally unprofessional. So a lot of students would basically skip a lot of the clerkship and just go study and then do really well on this shelf and do well on scores. So, but schools will look at what you do in a clerkship as a result. But again, grade distribution also is uneven, so you have to know that as well. There's another school in St. Louis, not named SLU, that 60% of their students get honors. So like, basically that just sorts out half the class. So like you don't understand if they were like honors, like the best in their class, or just like average, which is still honors. So there's a lot of goofiness with that I think schools are trying to get better about, but it's still very, very challenging. What I would say, just to finish this out, Luke, so a good thing to do is pay attention to where people have matched, particularly in the last 3 to 5 years when you're kind of getting closer. So it does a really good job. They have really strong connections to a lot of the California schools. We have students that go to all the top programs in the country. So there's always kind of a connection of somebody being somewhere. Reach out to ask them, and if they get a good connection, they always can put in a good word for you. It doesn't hurt. So, but the name goes pretty far. Students can go to a lot of different places based on their preference of where they want to go geographically or by school. You're welcome. Sorry. Any other questions?
I had a question, particularly about like in 3 years, we kind of talked about being graded a bit. Whenever students come into the clinic, what factors make them stand out to you?
Yeah, so for M3 for medicine, you're going to be on the inpatient side. So usually it's 4 weeks at SLU Hospital and 4 weeks somewhere else, either at the VA, St. Mary's. I think you also go to Mercy too still. For SLU and for the VA, you're almost always embedded with a resident team. And the residents, they don't have an outside influence, but a big part of that. So again, it's all these soft skills. So like one, it's obvious whether or not you know stuff or not. So like what you can do about that is like when you're seeing a patient you're not sure, certainly read up on that topic, ask your resident about it, ask the attending when you're on rounds. Often we'll ask you in medicine, like, what are some topics that you're unfamiliar with, so we can make sure to cover those in some of our teaching sessions. But that's the knowledge part. The other part is just like really enthusiasm and attitude. So, are you participating with the team? Are you helpful? Are you, when your patient needs something, are you volunteering to go get that taken care of and follow up with that? It's all those things of just working together within a team environment that really goes a long way. So, a lot of the assessment that goes in for the IM clerkship, and I'm sure the other clerkships, is, good patient rapport. Was it clear you were good and engaged with your patients? They knew you were. They clearly responded to you. How do you interact with the team? Are you kind of anticipating issues, or if you're not sure what's going on, asking questions about that? In medicine particularly, we're very good, and we very much pride ourselves on, like, we don't care if you're right or wrong about, whether or not the diagnosis is right, or, you made the right diagnosis. We want you to think about what you think is going on and explain why. And that explanation is really helpful for us to understand what you're thinking, what your thought process is. And, most of us, the great internists that are on our teams will tell you they're wrong often. What we get paid a lot of money for is not to be right all the time. It's like realize, oops, we made a mistake and correct it as quickly as possible, because it's really hard to do what we do. So those are really the big things. It's really a lot of soft skills of just being a really great teammate, interacting with the team, and having a really positive attitude. That goes a long, long way. Nice and competent. It works.
Thank you.
Now, whether or not that applies to surgery, I can't help you. I don't know. They're a different animal, but that's okay.
I think that's all the questions we have. So I wanted to thank Dr. Buckhold again, and thank you all for attending. And hopefully we see you guys at the next physician pathway session.
All right.
Thank you.
Thank you, everybody, for being here. And I'll see you in late April for cardiology. Get ready. It's going to be fun. Trying something new.
Thank you.
All right. Take care, guys.